So, dear audience, dear chairman, my PhD topic is about the investigation of pathomechanisms of heart failure and the new methods for its treatment with and without drugs. I'm a resident doctor at the Heart and Vascular Center, and my vision is to discover every single detail that can influence an outcome of a disease, and my mission is to find more personalized treatment for heart failure patients. I have two ongoing projects at the MP, both with the methodology of systematic review and meta-analysis. The first one is the predictive value of scar burden assessed by cardiac MRI on sudden cardiac deaths in cardiac resynchronization therapy patients. About my first project, what we know that it's a huge problem that the 5-year mortality rate of heart failure with reduced ejection fraction can reach 50%, out of which 10 to 20% die suddenly. We also know that scar burden or myocardial fibrosis is believed to be a major cause of sudden cardiac deaths. We have a great tool, cardiac MRI, which is the most accurate diagnostic tool for assessing scar burden. ICD can abort sudden cardiac death events, so it's quite useful for these people getting sudden cardiac death event. And what we want to know is that which device to choose, ICD, CRTD or CRTP, because the good decision could save more lives. The missing link is that there's no clear evidence in the guidelines regarding the optimal device choice. Our clinical question was that what is this association between the degree of scar burden assessed by cardiac MRI and sudden cardiac death in CRT patients? Our patient population were heart failure patients undergoing CRT, while the prognostic factor is scar burden assessed by cardiac MRI. We have one outcome, sudden cardiac death events. Our hypothesis is that the higher the scar burden, the more effective could be CRTD in reducing sudden cardiac death events. As for clinical implication, the optimal device choice could decrease the mortality, the morbidity, and even lower the costs and the complication rates. We have conducted our systematic search back in November, and altogether we found 16 eligible articles. Here you can see the baseline clinical characteristics of our research, and out of the 16 articles, we found more than 2,624 patients, and we dichotomized the patient population based on the reported late gadolinium enhancement on cardiac magnetic resonance. We found that there were 56% of the total population to be found scar burden positive. Our first analysis is with the measure of effects of odds ratio for a subgroup analysis of the short and the long time follow-up period with our outcome of sudden cardiac death. We found out that there were a 6.5 times higher risk of getting scar-positive sudden cardiac death in the scar-positive patient population, but there weren't significant difference between the short and the long time follow-up period. As for the univariate analysis, we find a 2 times higher risk of getting sudden cardiac death events in the scar-positive population. And we also made a multivariate risk model with a still statistically significant result of 1.7 times higher risk of sudden cardiac death events in the scar-positive patient population. And we also made a so-called competing risk model, which could give us the best estimate and the highest evidence. But as you can see, we didn't find a statistically significant result. But we still think that it's a clinically relevant one. Also, there have been a very large heterogeneity and a clear outlier data of Leiva's article. The reason behind that is that in that patient population, there were basically no reported outcomes in the scar burden negative patient population, as you can see with the very wide confidence intervals. We think that our main strength of our analysis is the subgroup analysis of CRT-only patients compared to the mixed cohort of ICD and CRT patients. What we find at the CRT-only patient population, there wasn't significant difference between the scar burden positive and the scar burden negative patient population, although in the mixed cohort there were. What is the reason behind that? We think that due to the reverse remodeling of CRT, it could diminish the incidence of sudden cardiac death events. Our strength is that it was the first meta-analysis focusing on a CRT population, and we have a large number of patients. But although there are some limitations, of course, like that these were not only CRT patients, we have ICD patients as well, and our initial aim was to assess a cutoff value that we couldn't find, and we didn't make a subgroup analysis for CRT-P and CRT-D. As for conclusion, we could say that the high scar burden is associated 2 to 6 times higher risk of sudden cardiac death events, and the CRT-only group, the number of events were very low. As for implication, the scar burden can help assessing the sudden cardiac death events, and for implication for research, that's clear that randomized control trials are needed, as all these articles, the listed 16 articles, were observational ones. As for my status, I'm just waiting for the language check, and hopefully I can submit it to the Journal of American College of Cardiology Clinical Electrophysiology this week. I have a second ongoing project which investigates the effectiveness of non-furosemide drugs with diuretic effects in the management of acute heart failure with the methodology systematic review and meta-analysis. We know that loop diuretics worsening the kidney function on long term, and they have a high mortality rate as well. There's a phenomenon called the diuretic resistance, which is also a problem in acute heart disease. On the same time, acute heart disease has a poor prognosis and has a high rehospitalization rate to 25 to 13% in a 60 to 90 day. What we need to know that there are some new treatment options with remarkable diuretic effects, which were recently relieved for SGLT2 inhibitors, acetazolamide, hydrochlorothiazide, diuretics, and MRI. Our aim is to evaluate the diuretic effects of non-loop diuretics compared to furosemide in acute heart failure. As for the patient population, we are investigating patients with acute heart failure. Our intervention is SGLT inhibitors, acetazolamide, diuretics, and mineralocorticoid receptor antagonist compared to IV furosemide. We are having outcomes of natriuresis, raises, the eGFR level, serum creatinine, electrolyte levels, body weight, and visual assessment score. We also want not only to investigate the diuretic effect, but for secondary outcomes, the length of hospital stay, the readmission rate, and the in-hospital mortality. Here's my systematic search. As for summary, I have these two ongoing projects, and thank you very much for your attention.
Thank you very much. Are there any questions?
Richie, the results of your first study are very clinically relevant, and as far as I understand, they're hot topics in cardiology nowadays. Other than publication, what other dissemination strategies did you have or you have for the future? Did you present this in congresses? Are you going to present it in congresses? And how successful were you in communicating your results to your colleagues?
Thank you for your question. I think it really is a hot topic. For example, in the ESC Congress, the European Society of Cardiology just had a congress, and I had an accepted abstract with this topic, and there were in the late breaking session in the ESC Congress with this cardiac resynchronization therapy for upgrade patients. So I really hope that, although I conducted my systematic search back in November, and now it's quite a few months going on with the project, I think it still have its relevance, and I really hope that they're going to accept one of the journals. Any other questions?
Any other questions? I also have a question. So the first is regarding the first study you showed. Shouldn't you subdivide the scar-positive patients based on the localization of the scar? Does the where matter?
This is a very good question. Thank you very much. We wanted to also assess the localization, but unfortunately, there are very limited data on that. But it's definitely true that, for example, what is very interesting is the ischemic and the non-ischemic etiology, where, for example, the ischemic ones have special localization. For example, after myocardial infarction, based on which arteries are supplying this myocardial part, there are localized scars. Although in the non-ischemic etiology, the ischemic, the myocardial fibrosis is not localized, but it's much more homogeneous. But other articles found that although you would think that in the ischemic etiology that there's a clear higher incidence of these sudden cardiac death events, still in the non-ischemic region, there's a high burden.
Thank you. Another question regarding the second topic. So what is the current state of the art regarding the role and expression of SGLT2 in the heart? And what is known about the direct cardiac effects of SGLT2 inhibitors?
This is a very good question. We know SGLT2 inhibitors, they were developed for an anti-diabetics, first of all. And then after all, they researchers found that these drugs are useful in chronic heart failure. And they established guidelines as the one of the out of the 5 drugs to use as a must-use drugs, chronic heart failure. But recently we just found out that in acute heart failure they are also useful. They are not only, we have 2 SGLT inhibitors, SGLT1 and SGLT2 inhibitors, and mainly SGLT2 inhibitors are expressed in the kidney, but we found out that there are SGLT1 inhibitors expressed in the myocytes as well. So they are not only have direct effects in the kidney as provoking more urine, and it's helps to get the congestion, but it has a direct effect on the myocytes as well.
Thank you. I'm not aware of those SGLT1 inhibitors, but I've just seen a recent paper showing that in diabetic patients, SGLT2 gets upregulated in the cardiomyocytes. That's why I was asking that question.
Yeah.
Thank you.